So the last session for the day, the case is Ascites and Hypoxia. Presenter Dr. Manjurhusen. Moderator Dr. John Matthai. Panelists Dr. Shaji Marar, Dr. Winita Hardikar, Dr. S K Yachha, please.
I'll let you only talk.
All right, this is another interesting case, and it's a little difficult. So we'll, I think, go through the discussion a little quicker. Oh, you got to
Yeah.
Yep. Right.
Good evening, everyone. And it is interesting to see such a large audience at 5:10. And I'll be starting my case. It's a case of ascites, and it is not so curious and interesting as sir just mentioned, but it is more of a simple case with how it progresses and more of a natural history of the disease.
No, don't start by saying it's not interesting. Yeah.
So the history goes this way. This is a 3-year-old girl who was born of non-consanguineous marriage, who was full-term normal vaginal delivery and had birth weight of 2.8 kg. She was otherwise fine till the age of 8 months when she started with acute diarrheal illness, which was of 10 days duration, and she had 10 to 12 episodes of watery motions per day, which was without any blood or the mucus in the stool, and it was associated with reduced urination, lethargy. She needed hospitalization and IV fluids. 3 days after this diarrheal illness, she had a generalized abdominal distension without any fever, vomiting or jaundice. Weight at the at age of 8 months was 7 kg, which was between 5th to 10th percentile. Now on examination, this child was vitally stable when she had come to us. She was mildly pale. There was no icterus, lymphadenopathy, edema fit, clubbing or cyanosis. On abdominal examination, there was generalized distension of the abdomen with 3 cm hepatomegaly. There was moderate ascites and dilated prominent veins around the umbilicus. There were no veins in the flank or at the back, and other systems were unremarkable.
Right, let's stop at this point. Can you tell us that when was this physical examination findings? Was it on the day the abdomen started distending or much later? Just go back to your previous slide.
This is at the time when the abdomen started distending.
That means 3 days after
3
the
days
diarrhea.
after the diarrheal illness.
When the child came in, that's the findings.
Right, sir.
Yes. Any comments from the audience, or yes, anything from the audience? Here's an 8-month-old who's picked up a watery diarrhea and then develops abdominal distension. And next slide, you find moderate ascites. Yes, any comments from the audience? Ascites and hepatomegaly following a diarrheal illness. That's the problem. 8-month-old. Ascites is there, significant ascites and hepatomegaly following a...
Can I?
No, I think we need the ordinary people, not the high-end people. Yep.
Not the extraordinary.
The Aam Aadmi, yes. Yes, let's get the Aam Aadmi involved, yes. Yes? Yes?
Thrombosis of
Venous thrombosis due to dehydration due to diarrhea.
Right. Was the dehydration diarrhea severe enough to cause dehydration?
Yes, absolutely. She also had oliguria, needed IV fluids, hospitalization, lethargy. So it was a significant severe diarrheal illness.
Right. And now thrombosis where? Hepatic venous thrombosis following it. Now to the panelists, Dr. Yachha.
Before panelists, Aam Aadmi.
No, you're not Aam Aadmi. You're some other Aadmi, yes.
First question, what happened to the diarrhea? It became passive?
Absolutely, sir.
Dehydration got corrected?
Yes, sir.
Sir, mic लीजिए.
My point is that this patient has hepatomegaly, has ascites, and veins around the umbilicus which you described are dilated, tortuous and engorged,
Right.
which suggests that there is a liver disease in this patient. That is the lead from here. You emphasize that there are no flank veins, there are no back veins, which means that there is no IVC obstruction at the west. So we will only say this time there is a liver disease in this patient. Now what is the kind of the liver disease? That's a separate issue, unless we discuss it further. Let us have. Can
Yes.
we discuss?
No, I
That
think
also.
Dr. Abba, you know the
I know
story.
the case, so I'll just cover in for Dr. Shaji.
Okay, right. So you pretend you don't know.
Yeah.
Yep. Yeah.
Before going to the next slide, I want to ask, everything pointing towards acute Budd-Chiari. So is this clinical finding suggesting acute Budd-Chiari? This patient came with a diarrhea, dehydration, developed abdominal distension, you have hepatomegaly which is not tender, you have prominent vent which is extremely uncommon in within 3 days of onset of Budd-Chiari syndrome. Is there?
Yes, but I think Dr. Yachha is tending to believe that it's a primary hepatocellular disease rather than an obstruction.
See, what we will not attribute it to Budd-Chiari because the time shortage is there, very
Right.
short. They come with hepatomegaly, tender hepatomegaly, there be a degree of jaundice in those patients.
Before
and
ascites.
veins will appear later. It's
No, I
not
mean,
that.
that's-
It can be primarily a liver disease. That is a possibility here in this patient.
No, I think that's the point that I asked. Did you see it 3 days after the diarrheal illness or did you see this child much later?
Second thing is, if you get veins around the umbilicus in a patient who has had severe dehydration, this could be a selective thrombosis of the left branch of the portal vein. Then you will get the veins. No, yes, not otherwise. But that's a very, very rare situation to occur. You don't get.
You don't get
You don't get.
hepatomegaly.
That's another point.
And ascites is also less likely.
Ascites
Yes,
will be mild,
yes.
it won't be moderate ascites. Yes, anybody else, any suggestions? Otherwise, let's proceed. Yes.
So on investigating, the hemogram showed hemoglobin of 10.6, white cell count of 14,000 and platelets of 3 lakhs. The bilirubin was slightly elevated 2 milligram per cent, which was predominantly direct. SGOT was 96, SGPT was 85, ALK-phos and GGT were normal, albumin was 2.9 gram, globulin was 3.1 and the INR was 1.2. Creatinine and electrolytes were normal. The sonography of the abdomen showed hepatomegaly with moderate ascites. And there was mild splenomegaly as well, which I have forgotten to write here.
Mild means significant splenomegaly.
Yes, sir.
So don't say mild. It is there.
This is what the sonologist write.
It's
No,
there.
again, this was done soon after admission.
Yes, sir.
Soon after admission. Yes? Anything
what-
more you want? Anything more you want in the preliminary?
Yeah,
You have any more?
these
Yeah.
investigations point to the fact that we have got liver dysfunction in this patient. We have raised transaminases with low albumin and INR is reasonably maintained. So there is a liver injury in this patient.
Right, so
That's
you would
what we can make from here.
So you would think of venous thrombosis, but
No,
keep
no,
it at the
no,
back
no.
of your mind.
I would
Or
think of liver disease.
primary liver disease at this point.
Liver
Yes,
disease in this patient.
Dr. Ujjal?
Again, I'll put my point. This child does not have acute Budd-Chiari. This child, whatever it is not fitting. It could be chronic Budd-Chiari, but not acute Budd-Chiari. We
Yeah,
need Doppler.
That's right.
So we did a Doppler on this child, and it showed a short ostial stenosis of the right hepatic vein. The left hepatic vein and the middle hepatic vein were almost streaky and fibrous band. And as we see here, there is ostial stenosis on the in the right hepatic vein.
Right.
And also there was significant, or there were venous collateral seen in the on the Doppler, as well as on the right hand side we can see. So these are the color Doppler findings on this child.
So where are we?
Now, what is the Doppler finding now? It suggests what?
It is suggestive of Budd-Chiari syndrome involving all 3 hepatic veins.
That's it. It's a chronic one.
It's a chronic
because you have
Budd-Chiari
collaterals there.
Absolutely, sir.
I think
Not acute, what Ujjwal is telling you, because
Yeah.
they are likely to digest acute in the setting.
Yeah, I think that's an important point to make. This looks as though the child has a Budd-Chiari, but it's a chronic Budd-Chiari. That the diarrhea has brought, it's a red herring. It's brought something else to the surface. And I think, would somebody like to say how you decided that it's not a acute Budd-Chiari but a chronic Budd-Chiari for the audience?
We have described.
Yep.
We have
You
already
have-
described that there is no hepatocellular, there is no elevation of jaundice.
Yes.
This bilirubin, there is tenderness of the liver is not there. And you will not get collaterals in that following Doppler.
Presence of the
You
collateral,
will find a
comma-shaped
thrombosis.
collapse.
I think that's the key there. If you find collaterals, that means it's a chronic process.
Yeah.
You will not get it in an acute Budd-Chiari or in any acute process. Collateral tells you that it's been going on for some time. Yes.
What about, sir, presence of splenomegaly?
Spleen is there as a part of chronic Budd-Chiari syndrome.
Chronic venous
There is
obstruction.
hepatomegaly. We expect that the spleen may also get enlarged
Yes.
as a part of portal hypertension.
Isn't absence of spleen with all this would have been stronger No.
No, it would depend upon the stage at which you are diagnosed. It would depend upon that.
Yes, go ahead.
At the same time, the ascitic fluid examination was also done, which showed WBC of 282, lymphocytes were predominant, protein was 1.7 gram and albumin was 0.7. Basically, serum ascites albumin gradient was 2.2, suggestive of portal hypotension. Yeah, so basically serum ascites albumin gradient is the difference between the albumin in the serum and in the ascitic fluid. And if this is more than or equal to 1.1, it tells us with accuracy of 98% that the ascites is related to portal hypertension.
One pointer here you should highlight. This protein 1.7 seems to be undigestible.
Right.
See, whenever you get total protein so low, that means there is something else in the intestine. Then.
Agreed, sir.
Losing. Or it is the reduced intake. With 1.7, I have never seen.
Ascitic fluid.
Oh, yes. Sorry.
Yeah, just
You have to.
Ascitic
You must
fluid.
mention their ascetic fluid.
So I have written
Yeah.
ascitic fluid examination.
All right, all right.
Okay, one more point I want to make here. The total cell count, now just don't get carried away by that 90% lymphocytes. See what the total count is, and don't interpret this as tuberculosis because it's 90%. Typically, you would have much higher counts in tuberculosis. Don't see the absolute lymphocyte
No, I
count.
think don't look at
Yeah.
one value, one single finding. Put the whole thing together before you
No, we are
interpret.
getting high sag, no, here.
Yes.
Yeah, and what
We are
people
high
tend to
sag,
see
yeah.
90% and
So
call it.
I think you all understood what the SAG is all about. Does it need to be repeated? Now, I think remember this, it's a good investigation and it's got above 95% sensitivity in diagnosis. So look at the SAG as an important marker now. Yes, go ahead.
She also underwent thrombophilia profile, which was negative in the form of normal protein C, S, antithrombin 3 homocysteine levels, negative Janus kinase mutations, factor V Leiden and prothrombin gene mutation. So we could not find any thrombophilic tendency in this child.
One second. This question to Winita. How often do you find a positive thrombophilia workup in Budd-Chiari or in extrahepatic portal hypertension? We all do it, but I
We hardly see any Budd-Chiari at all, so that's the first thing. But in terms of pre-hepatic portal hypertension, portal vein thrombosis, we see protein CS reductions quite often, but that is secondary to the pre-hepatic portal hypertension. It's not a primary thrombophilia. So I think that's an important point, is that if you see a portal vein thrombosis and you see a low protein CNS, it's not the effect.
it's not the cause.
It's not the cause, sorry.
not.
It may be an effect.
Dr. Yachha, you want to comment on that?
Yeah, see, as far as you said, extrahepatic don't, let us not discuss that issue, but for Budd-Chiari syndrome, adult studies are available in India.
Yes, there's one from KEM and even from.
They have shown around 30 to 40% of these patients have got a hypercoagulable state. I think we are not actively looking at it in our study. Vibor, we have any figures? We are doing it at the moment, but we have not analyzed our results.
But do you
But
get
we
them
feel-
positive?
Yeah, we do get some patients, but exactly I don't know the figures. We are proactively looking into this aspect. But generally what we find thrombosis of idiopathic nature, IVC blocks, which are actually the membranous blocks, or there may be actual thrombosis there, which is structure of that area. This is what we find for chronic Budd-Chiari. Here, this is in order. The reason is this child is very young. Might be that there is a hypercoagulable state which is predisposing this child to the development of chronic Budd-Chiari syndrome. That investigation is perfect here.
So considering that the child is very young,
Yes,
likely
yes.
that there is
You
a
should
coagulable
look for
state, and therefore this is in order.
Yeah, just one point, that when you have multiple things which are low, like protein C, protein S, and antithrombin 3, it's usually because of a chronic liver disease and not because that
of the-
is actually deficient, because we know that all these proteins are being produced by the liver. So if you have multiple, then you should think of a liver disease, chronic liver disease, causing them to be falsely low rather than an actual deficiency of any of these.
That's right. And there was an article to that effect. You see, there is a consumption. The same thing holds true for EHO also. There is a consumption coagulopathy. With the result, these factors are used. And they have shown concomitantly, there was a very good article actually in Gut, which showed that also in cirrhotics, you have got secondary actually decrease of these coagulant factors, hypercoagulable states. So therefore, it doesn't
Mean much.
mean much.
So basically would we say that,
If you see at multiple sites,
right,
multiple sites, then assumes importance. Then
Okay.
you may have to give them anticoagulation or whatever kind of therapy has to be.
Right. Go ahead.
So this
Dr.
child
Shaji
was,
is-
after the diagnosis of Budd-Chiari syndrome, chronic, she was started on diuretics and anticoagulation, which is the treatment for the Budd-Chiari syndrome. Initially, it was started with low molecular heparin, which was overlapped with warfarin, and target INR was kept between 2 to 3. And despite these diuretics and anticoagulants, her ascites kept on progressing, and she needed paracentesis.
Now, one
Dr. Yachha,
point-
if it was a
No,
chronic
no,
Budd-Chiari,
Dr.
would you
John,
have?
John, one point, why we have given anticoagulant?
That's what I was going to ask you.
The question is, when we are not showing any hypercoagulable state, there is no acute thrombosis, then why have we to give anticoagulation? We give anticoagulation only after we have done the stenting.
Right.
Because we want to keep the blood in a fluid situation. The stent block does not take place.
Yeah, and I
So-
think that was the point that I was going to make, that I'm not sure there's a role for the anticoagulation in this particular instance, at least not at this stage. We'll probably need it at a later stage, but not at this stage. Yep. Yes, go ahead.
Ascites progressively.
So the patient underwent hepatic venography, in which the left and the middle hepatic veins could not be cannulated. Right hepatic vein showed ostial block, and which was dilated by balloon venoplasty. On the left hand side we can see there is balloon in the right hepatic vein, and there are also multiple venovenous collaterals, which as we see on the right hand side of
This
the
is the transjugular
presentation.
route you have taken.
Absolutely, sir.
Transjugular route.
Yes, sir.
Dr. Shaji is here.
Yeah,
So
I
all
think-
questions related to interventional radiology may be directed.
So after this right hepatic vein venoplasty, balloon dilatation, her ascites
Yeah,
improved, her diuretics
would you like
were-
to tell us something more about the management at this
Yes.
stage? Just go back to the previous slide and tell us what, for the audience, what.
Yes, at this stage, the idea of doing an intervention is to provide improved venous outflow from the liver by either doing a hepatic venoplasty or a stent, if possible. If it's an IVC block, you do an IVC plasty. Considering the young age of the child, placing the stent is not recommended because the stent occlusion is very common, especially with the setting of Budd-Chiari. So in this stage, just as a palliative time-buying procedure, you do hepatic venoplasty, hoping that at least temporarily the venous outflow is improved.
So this is a palliative procedure rather than anything very definitive. Yeah, go ahead.
So with this procedure, palliative procedure, her ascites improved, diuretics were tapered, but after 8 months of stable course, she had recurrence of ascites with this time variceal hemorrhage, so which was treated with endoscopic sclerotherapy and
Following your intervention, how early you have done a repeat Doppler to see that there is a patency in that area?
So the repeat
Variceal hemorrhage you will not get easily unless the stent has got blocked and the disease has progressed.
Right, sir.
And what about some anticoagulation at that stage?
Which was continued with the INR, which was kept in the therapeutic range 2 to 3.
Anticoagulation needs to be continued.
Yeah.
John, can I make a point?
Yeah.
Dr. Shaji, this is related to you. Only plasty without putting a stent, how effective it is. See, here what we have seen a picture, this is not stenosis, absolutely blocked.
Yes.
So in that blocked vein, if you just dilate it,
Yes.
it will open temporarily, but it will go back to the same position. If it is
Recurrence.
a partial narrowing,
Yes.
where there is a flow, then if you dilate that might help.
Yes.
But is it that technically it is not feasible, or we don't have that particular size stent, that's why you have not used stent, or any other reason?
Yeah, it's not because of the technical thing. Because the size of the vein, I missed the initial part. I'm sorry about coming late. What's the age of the kid?
8 months.
8 months.
8 months. See, in an 8 months kid, the hepatic vein is extremely small.
Then at what age is this? He is 3 years old.
She's 3 years old now.
Now.
But the
But
history
this-
dates back from 8 months.
So
you
it's
have
an
done it 8
extremely
months.
Yeah.
it's an extremely small vein. We have a series of pediatric Budd-Chiari patients which we have already published also. We have done almost an equal number of patients afterwards. What we have found from our experience is that when the hepatic vein is more than 6 millimeters, we tend to use a stent. This is just an arbitrary thing, maybe from our experience. There is nothing to substantiate this, but when the hepatic vein is very small, placing a stent, despite it's a slow flow system, it's a venous system. Despite anticoagulation, if you put a stent in a 2 or 3 millimeter vein, it doesn't remain patent. So once the stent gets occluded, we don't have a chance of a re-intervention. So we try to do only an angioplasty, especially in very small kids.
So as she had ascites, recurrence of ascites and GI bleed, which was variceal, the repeat hepatic venography was done. It showed there was high-grade wrist stenosis at the right hepatic vein ostium, which was dilated in the past with significant gradient, and this time the left hepatic vein was narrowed. So the right hepatic vein stenting was done across the ostium. As we can see here, there is a stent placed in the right hepatic vein across the ostium, and at this time her age was approximately 22 months.
It's almost 2 years.
Oh yeah.
So would have reached the numbers that you're talking about.
Yes, yes. Now you can see the venous.
We have gone through that article 2.5 years back, JPGN article.
Yes.
We are aware of that.
Yeah.
Yes, now you can see this vein is slightly bigger, it's more than 6 millimeters, so we can safely place a stent. Having said that, there is no guarantee about the patency of the stent because it's a procoagulant status, plus it's on the venous side, so we need serial follow-up and if needed, repeated interventions.
Correct, that's right.
And
So
the anticoagulant, what do you anticoagulate them with?
Warfarin?
Warfarin.
Yeah, in the early stage, we do it with low molecular weight heparin. Immediately post-procedure, initially we were using unfractionated heparin, but we found that monitoring PTT was quite tedious and would be difficult, so we've switched on to low molecular weight heparin, and then we go on to warfarin and maintain the INR between 2 and 2.5.
So the INR to be between 2 and 2.5, and you use warfarin. Yes, go ahead.
So after right hepatic vein stenting, she was again clinically better for 6 months with good control of ascites, good compliance for the INR and the warfarin, and there was no variceal bleeding. But she was found to have clubbing and hypoxemia with SpO2 of 83% and PO2 of 56 millimeters of mercury on routine follow-up, and chest examination clinically and chest X-ray were normal. And as we can see on this photo, there is bulbous enlargement of this nail angle, and this was suggestive of clubbing, and there was hypoxemia.
1 second. Dr. Yachha, Winita, would you like to, what's happening? She's moved on to a cardiovascular complication from Bacchiari.
Textbook description, so I'm sure everybody in the audience knows the answer already, but this is hepatopulmonary syndrome, I think, with clubbing, hypoxemia in the setting of somebody with liver disease and portal hypertension.
Yes, so now the question of hepatopulmonary syndrome comes in. HPS.
Any dyspnea in this child? Cyanosis, dyspnea?
No dyspnea.
No dyspnea, no cyanosis, and
only hypoxia.
Only you are getting clubbing and hypoxemia. On
I think there is clubbing and mild cyanosis. There is
cyanosis, yes.
Yeah, from
it appears from this picture.
This was supine. We did not demonstrate orthodeoxia in this child.
All right.
So hypoxia with clubbing.
SpO2, how did you measure? I'm just asking you.
Sorry?
How did you measure this SpO2?
Pulse oximetry.
Yes.
Conventional pulse oximetry.
Say that we have done pulse oximetry. It has been found to be 83%.
Yeah, so SpO2 was measured by pulse oximetry and the PO2 by arterial blood gas analysis.
Vinita, would you like to tell the audience when would you suspect HPS? I mean, you said it's a classical textbook case, but when would you suspect?
So what we teach our students is to keep looking at the fingers in anybody with chronic liver disease and anybody with portal hypertension. And then in the clinic, we just have an oximeter. So we do a 5-minute oximetry. We don't usually do lying down and sitting up, etc. We just, because it has to be fairly significant and the treatment options are limited. So you need to find something, I think, what Professor Yachha was saying, something clinically significant.
Criteria which is taken is if you suspect, you do pulse oximetry and you find oxygen saturation less than 92. And then it is in spine position. And when you make the child to get up, there will be a further fall by 4%. So that is a method of screening. And thereafter you have got to confirm this condition by POO2, that is one. Another thing is that echocard, we are doing a prospective study.
Bubble.
And
I think clubbing is an early sign.
Clubbing,
I think looking at the finger is like somebody said, it's not a ultrasound diagnosis, it's an eyeball scan diagnosis. I mean, look at the fingers with your eyes and that gives you a diagnosis. It's not a CT scan diagnosis, it's an eyeball scan diagnosis. Yes, go ahead.
So then
was it once you have given oxygen to this child?
Yes, sir.
Improved?
So it got corrected with that?
With oxygen it was getting corrected.
So it's a type 1 basically.
Type 1, yes sir, absolutely agree. So to confirm the diagnosis, patient underwent macroaggregated albumin scan, which revealed hepatopulmonary syndrome with shunt fraction of 66%. In these images, if we can see, on the upper images A and B are the lung scan where the macroaggregated albumin gets trapped. And these are the images on the brain, on the right side and the left side. And we compare the tracer uptake on the lung scan and the brain scan, and then the shunt fraction is calculated. Normally the shunt fraction is less than 6%, and when it is more than 6%, it is virtually diagnostic of hepatopulmonary syndrome.
Winita, how common is hepatopulmonary syndrome in the setting of something like this? Or when would you tell the audience, when do...
Yeah, we don't actually see it very commonly. We look for it a lot and we teach it, and it's a great exam case, but in practice it's relatively uncommon.
Only used to fail.
It's only about less than 10%.
It's used only to fail students.
We see it. The other thing is I'm interested in the cost of this scan compared to shaking up a bit of saline and sticking it into a vein and doing an echo. It's much cheaper in Australia. I don't know how much it is here.
A contrast echo.
Actually,
not contrast, just agitated saline. Yeah. Oh, you call it contrast. Okay.
Contrast echo.
There are 6 studies in the world literature at the moment, variable from 3% to 17 to 18%. In liver disease, intrahepatic group. Now, lately we have done the prospective study on EHO also, and we have found a small proportion, in fact 3 or 4%. Am I right? 3 or 4% of hepatopulmonary syndrome in EHPV also. So it is not what Winita is saying, the incidence is not that high, but we need to suspect wherever there is a blue issue. We have seen a number of patients, but we have not analyzed them further previously. They do develop this clubbing, they have got cyanosis, they are blue, and that might be actually an indication for transplantation.
Okay, go ahead.
As sir mentioned, patient was advised liver transplantation, but parents were reluctant. Again, she had variceal hemorrhage 4 months after HPS diagnosis, which was managed endoscopically with sclerotherapy. So now the child is 3 years old, has moderate ascites, weight is just 10 kg with height of 83 centimeter, chronic wasting and stunting, albumin of 2.6 grams with bilirubin of 3.3 milligram %. INR is 1.9, SGPT is 40, SGOT is 65. Her pediatric end-stage liver disease score comes to 17, and now this time she's being considered for living donor liver transplant with mother as a potential donor.
Tell in these patients.
For the
HPS. And I think one reason why you may be not seeing is because you are transplanting these patients much before HPS comes in. And we have seen a lot of these cases in the EHBA who have not got successful, and the incidence within 1 year is very, very fast. They come up with HPS very fast.
That's right. Excuse me. So 1 point.
Stent was not reevaluated because clinically it was supposed to be blocked. So diagnosis was Budd-Chiari syndrome involving all 3 hepatic veins, post-venoplasty and post-stenting, which has got restenosis, recurrent variceal hemorrhage, severe hepatopulmonary syndrome, and now being considered for living donor liver transplant with PELD of 17. So, ladies and gentlemen,
let's just wait. Before they go home, let's...
One more comment.
Don't send them.
Vinita, in a setting of... I'm asking this. In a setting of Budd-Chiari syndrome where we are not sure about the underlying coagulation disorder, if you go for liver transplantation, is there any increased risk of hepatic artery thrombosis or hepatic venous thrombosis after transplantation? Or do you need to take any extra care for that?
Yeah, I think what you're pointing out is that we don't know whether there's any thrombophilic condition or not.
Underlying Budd-Chiari.
But generally, most of the thrombophilic factors are made by the liver, and we know from our studies, one that you published, that's why he wants me to point it out, Ujjwal published a study looking at thrombophilic factors in the post-transplant setting. We know that within 5 to 6 days, protein C comes up. Within a week, antithrombin 3 comes back to the normal level. So even if there was a thrombophilic tendency previously, by the transplant.
If you transplanted this child now, what would you think is the prognosis for this child?
How old was the child again? I forgot, sorry.
Now child's 3 years old, is all...
3 years old. So, and
Yeah,
he,
got
was
severe
he was in very good condition, apart from the mild hepatopulmonary syndrome.
Yeah.
So we would expect a 10-year survival of around 90%, and we would expect the hepatopulmonary syndrome to resolve in the vast majority.
So if you do a liver transplantation, this
But
is
it
reversible.
can take months, I should say. It can take months. It
Yep.
doesn't resolve immediately after the transplant.
Yes, Abha, you want to say
Generally,
something?
what we have seen, if you do stenting, angioplasty followed by stenting in Budd-Chiari syndrome, see, actually you may develop stability of the liver functions. You may develop, actually, there may be a thrombus or progression of the liver disease. But it is very difficult to find regression of the liver disease following angioplasty and stenting. So it is a sort of, I would say, we also are doing a lot of stenting and angioplasty, but it is not uncommon to find restenosis, rethrombosis, and it's very expensive procedure. For poor patient, it's extremely difficult.
No, I think he was trying to talk about the 6 millimeter guideline
that
for
is right. I
stenting.
think
That's a
at 9
technical.
months, 8 months, it will be very difficult.
Very
to
difficult.
assess
I do not.
Yeah, I think we are basically buying time. You know, because in an 8-month-old with refractory ascites, you really don't have too many options. Either you just give anticoagulation, some of them may just settle, they form collaterals and the ascites goes away. But in majority, you need to have some intervention. So at 8 months, you have a choice of going for a transplant, which itself is not a great option, or do something as a stopgap. And the longest follow-up which we have is 8 years. So I think, you know, now we have a girl who was... who had a stent at 8 months and now is 8 years old. And now she's come with a stent block and problems, but we've got enough time. So I think what these interventional procedures are really doing is giving us time and buying time. And
I think looking back, I think we would still have managed the case the same way as it was managed 3 years ago. I think nothing much would have changed looking back. We couldn't have prevented the hepatopulmonary syndrome. We could have only picked it up as early as it came, rather than anything else. Shaji, would you want to add something more?
Only in Budd-Chiari, but also other conditions of liver disease where you can develop hepatopulmonary.
I think we need to look for it, because I think we are not looking, yeah.
Seema, you are looking? Yeah, we are looking at hepatopulmonary syndrome now is coming up very, very well.
No, I think it's basically because the cyanosis comes late. They only have hypoxia. So to try and say somebody with a liver disease needs a pulse oximetry on follow-up is where the problem is. But I think we need to look at it more closely.
Shaji, your comment, then I'll make one.
Yeah, there are not too many options with interventional radiology for hepatopulmonary syndrome, except if it's a Budd-Chiari syndrome with an suprahepatic IVC block, where doing an angioplasty or a stent, it takes care of the portal hypertension as well as the hepatocyte dysfunction. Tips, there are few case reports of tips doing reasonably well, at least in the short term for hepatopulmonary syndrome, but there is no long case series or randomized controlled trials. So tips, we don't know whether it really works. In another interventional radiology option is in macrofistulae that can be embolized.
Yes.
But the percentage of macrofistulae in hepatopulmonary syndrome is maybe less than 5%.
One. Yeah.
Yes.
This is, Winita, you can also chip in. This is a classical case of severe hepatopulmonary syndrome. This child, PO2 was 59. This falls into the category of severe form of hepatopulmonary syndrome. What is the natural history of this kind of patient following transplantation? Is it that all hepatopulmonary syndrome resolves with transplantation, or some of them they don't? And is there any higher risk of complication of transplantation of this setting? Severe hepatopulmonary patient is subjected to liver transplantation.
Do you want me? All right. So I agree with you, it is severe, but at least in our experience, still most of them do very well. The recovery rate, I would say, is very slow. So the clubbing is still there 12 months after transplantation. You can still see them clubbed, and the oxygenation will slowly improve with time. In terms of specific complications, intraoperatively, we don't have any problem because you just give 100% oxygen and you can usually correct the oxygenation, so there's no problems during. The only other thing I'd say is that post-liver transplant, particularly in small children, because there's often a piggyback or because of the venous anastomosis, you often get a recurrent Budd-Chiari-like syndrome post-transplant because of narrowing of the hepatic vein. So ever if you get ascites or your clubbing persists, we still do reoxygenations and we regularly Doppler, and often we have to use our interventional radiology colleagues to put in stents after transplant as well because of narrowing in that area.
I have just one question.
Yeah, just one more point, that we need to continue anticoagulation after transplant also in these patients. It's very important. We can never stop it, ever.
I have a question that he talked
Any
about
question?
tips. Is it going to affect the option of liver transplant later?
No, the answer is no, especially in older age group. But technically, it is very difficult to place the stent just into the IVC in a very small kid when the IVC size may be 5-6 millimeters. Technically, it's a bit difficult in the pediatric, especially in the young children. In the adult, it's absolutely not an issue.
Any questions from the audience?
Excuse me, sir.
Yeah.
Sir, one point regarding the reversibility of hepatopulmonary syndrome after the transplant. There's a few subset of patients in which there will be permanent changes in the pulmonary vasculature. If it occurs, then the hepatopulmonary syndrome may not reverse. So these changes can be predicted after on pulmonary angiography. So there are specific changes that will differentiate between the two. So one can predict whether it will be reversed or not. I may not be able to detail these changes on that, but there is a literature available on this.
Any other questions from the audience?
Yeah, I think what he's referring to is type 2, where you have AV fistulae, which are, single isolated fistulae which can be embolized.
Which are very rare.
Yeah, but this we've decided is type 1.
Yeah, this is type 1.
So
any other questions from the audience? Any?
Also, chest X-ray is important. There may be a reticular pattern.
The basis.
Nodules, but here the chest X-ray
Was normal. Yeah, can we have the carry home message?
Summarize, consider Burchiari in children with isolated ascites. The ascites is usually out of proportion to the liver dysfunction. Pedal edema implies IVC obstruction or hypoalbuminemia. SAG more than 1.1 means portal hypertension and virtually excludes peritoneal diseases. GI bleed after shunt indicates varices, and do not blame warfarin if the INR is in therapeutic range. We have discussed much more details about HPS, and treatment is supportive and liver transplant is curative. And PELD is the calculation comprising bilirubin, INR, albumin, age and growth failure, which predicts 3 months mortality in those children who have chronic liver disease. And it is used to allocate livers by United Network of Organ Sharing. And liver transplant is curative in end-stage Burchiari disease.
I think for the postgraduates, I think they can go and read on PELD. I think there's no time to discuss that. Ladies and gentlemen, thank you very much.